Hi everyone, I'm Luke Reed, CEO here at Microba, but based on all of the names that I can see, most people know me already. So I'm very pleased to see a really great group of people here on this call. Everyone's taken the opportunity, time out of their day to join this session to hear directly from a key opinion leading specialist here who's using Microba's testing with their patients today. So many of you would have seen that we recently announced a strategic partnership with the Colonoscopy Clinic, which is one of the largest private gastroenterology services in Australia. They see more than 10,000 patients a year. So our guests here today are Dr. Dan Worthley in the middle there, who is a key opinion leading gastroenterology specialist, and Mr. Andrew Saunders, who is their managing director at the Colonoscopy Clinic. So I'm going to hand over to Dr. Sean Parsons, who's on the left, to moderate this session. Sean is serving as Chief Medical Officer at Microba. So Sean, on that, I'll hand over to you.
Thank you, Luke. Hello, welcome to everyone. I'm Sean Parsons. I'm a clinician entrepreneur. Pleased to be lending a shoulder here to the Microba cause, which is a really terrific one. This session today is really letting Dan share his experience about using Microba's products and how they've impacted on his practice. We are going to talk for 30, maybe 40 minutes, and then there's going to be a bunch of time for questions at the end. If you have questions along the way, feel free to put those in the chat and we will go through those. We can, if you want to ask those directly, when we get to the end, you can raise your hand in the Teams and we can go through the questions one by one. So I'll ask Dan, then Andrew for a brief introduction. And then Andrew, if you could just give us a bit of background on the Colonoscopy Clinic and size, magnitude, all of those sorts of things. Sure. That'd be wonderful. Over to you, Dan.
Sure. So I'm Dan Worthley, 48-year-old Australian gastroenterologist. Heavy research career, spent 5 years at Columbia University doing postdoctoral research. Came back about 10 years ago. And at that time, through some connections with Rob Knight and others in the US, became very focused on the role of the microbiome in colorectal cancer as well as in functional bowel diseases. And started a number of symposia around microbial healthcare. Through that, very early on, got sort of met Jean Tyson through Rob Knight, and then sort of have been following the story of Microba.
I noticed you had hidden it.
With Andrew, took over sort of our practice, and just have been sort of keen to be at the cutting edge of microbial healthcare, not just in Australia, but across the world, with evidence generating sort of new work. So that's me.
Fantastic. Andrew Saunders. I am not a gastroenterologist, but for my sins, I'm the son of a gastroenterologist. Probably strayed from healthcare for about 15 years. And then after telling mum and dad I would never work in healthcare, lived 5 minutes down the road from them when I was 35, that's where I ended up. That's about 10 or so years ago now. Incredibly passionate, family history of bowel cancer, gut health issues, really personally and professionally motivated to deliver just outstanding outcomes for patients, which we do and continue to do. In terms of our practice, Sean, and for the audience, we're largely Brisbane based. The practice has been around for about 40 years. 5 years ago, Dan and David, so Dan Worthley sitting next to me and David Hewitt took over the practice. We have since expanded, transformed. We provide care for 10,000 patients in Brisbane and the broader Brisbane area, a few referrals from broader Queensland as well every year. Mainly our practice, deep vertical around colonoscopy, which is safe, rapid, reliable bowel cancer prevention. So busy doctors in theatre providing endoscopy and colonoscopy care. Late last year, which is one of the reasons we're here as well and excited about the microbial space, is we acquired Associate Professor Graham Radford-Smith's practice, Integrated Gut Health. They do the broad horizontal of everything from IBD, IBS, DGBI, functional gut disorders. So guess with the deep vertical, the broad horizontal, we're well positioned here in Brisbane, have codified and digitized our model, safe, rapid, reliable access to care, and microbial healthcare and everything that we're doing with Microba is just a huge pillar of our growth going forward. We're big believers in the test, the outcomes it delivers, which we have seen and felt all the way through to end resolution with patients. And yeah, privileged to be here today. Thank you all.
Yeah, great, Andrew. Thank you very much. We're going to talk today about a couple of things. We're going to go through the Microbes products, which is the MetaPanel Advanced Pathogen Test and the MetaExplore metagenomic microbiome test.
Yep.
But maybe before we jump into that, could you give your views as a gastroenterologist on the broader trajectory of advanced pathogen testing and how metagenomics is changing that and enabling that?
So I think you won't find a gastroenterologist who doesn't think that gut health is integral to all aspects of gastroenterology. And I think increasingly you see in the broader population people who are engaged and eager to learn more about how their gut health promotes their overall wellness or their specific symptoms. But we probably, until fecal metagenomics, we didn't really have a way or a language through which we could articulate gut health and what it is. So, do you know what? There are all these cool numbers around 99.9% of your genes are actually microbial within your gut. They are transplantable, they are manipulable. The vast majority of your cells are microbial rather than your own. And this has engendered a great deal of interest. The initial research was around associations. The follow-up research have been around key therapeutic impact of the microbiome. And now we've had an impoverished means in gastroenterology of interrogating our patients. People see better than they think, and all we've done is look. And we've looked with human eyes at a tube. We've done some fairly rudimentary stool tests, which have been around really since since PCR was invented, looking at a small and debatable panel of a few different microbes. So it wasn't really until fecal metagenomics came along in a clinical sense that you could then utilise that and actually start to engage with your patients around not just whether they had bumps in their bowel or cancer, but actually go into how they could, through lifestyle, through antibiotics, through prebiotics, through probiotics, affect their symptoms. And so I think fecal metagenomics is gastroenterology, at least elementary tract gastroenterology, actually catching up with the 21st century. That's where, and the trajectory, Yeah,
5 years from now, how do you think we're going to manage this?
It is still early days. My dad's an 82-year-old ICU specialist, and he has a lot of stories. We do blood tests now at the drop of a hat. In Dad's day, when he was starting in ICU in biochemistry, they would produce a sodium and a potassium, and if you're lucky, maybe a chloride and a hydrogen ion, and that they got people to help them to interpret these small number of tests. I see microbial profiling through metagenomics becoming integrated into standard of care within the community, outside of specialist centres. I see it, obviously there is both the non-medical part of it through direct to consumer part of it. I guess that's an important part of it, but I see that there's a very strong, large tip of the iceberg being around symptomatic patients and, probably saving a whole lot of colonoscopy, which I regret to say.
Sure.
Yeah.
So, how much gut health problems, or what do you think is the prevalence of gut health, IBS, IBD to a lesser extent? And for the audience, irritable bowel syndrome is IBS, and inflammatory bowel disease is are the acronyms. How much of that do you think is out in the community?
So I know it's 1 in 3 Australians will have important chronic digestive symptoms. We hear a lot about the mental health crisis. Do you know what? And it's really important, and it's unsolvable with the current structure of our health system, which is reactive and all the rest of it. Do you know what? It's probably the best in the world, but nevertheless, we have ramping and we have mental health. But there is also a digestive healthcare crisis. Do you know what? It doesn't receive as much attention, but more people will have chronic symptoms that are unanswerable in the current construct of primary healthcare, certainly not tertiary healthcare, and the way that specialist healthcare is delivered is a challenge for addressing these. So to bring in new technology and new ways of applying that technology will have enormous value at the community level.
Yeah, I mean there is a problem. I mean, there's a lot of people out there with these problems. Can you just outline your kind of treatment algorithm, how you think about managing those patients? And I suppose I'm thinking here more about inflammatory. Irritable bowel syndrome rather than inflammatory bowel disease, so IBS rather than IBD. How do you think about managing that on a clinical basis?
So irritable bowel syndrome, so there are a couple of different flavours. The most common is diarrhea predominant irritable bowel syndrome. So these are types of conditions under disorders of gut-brain interaction, which means that there is not a biopsy or a blood test that will diagnose who does and who doesn't. It's a syndrome, it's a cluster of symptoms and signs, exclusion of other pathologies, and then implementing tracks of care. At the moment, those patients, you know what, not at the moment, do you know what, 10 years ago, 5 years ago, the way they would have been managed is with some routine blood tests. Do they have raised inflammatory markers? Some stool tests, do they have raised stool inflammatory markers or blood in their stool? And then the GP would be, sometimes, to be honest, dismissing. You know what? They're busy. They've got a waiting room full of folks, and they've got to crack on, and they don't think it's cancer. And this person will be alive to come back the next time, and we'll deal with it if it persists. So some of those patients come through to a specialist gastroenterologist, where they'll be seen. Specialist gastroenterology is highly skewed and rewarded for doing procedures.
Right.
And so these people will be seen, they'll be consulted on, they'll pay for that consultation. Depending on the person and the practitioner, a group of those will go forward through to tests such as endoscopy and colonoscopy. That may or may not then resolve that scenario and the person to be discharged back to the GP. We have a somewhat more holistic view at our practice where they'll then be engaged in a program with a dietitian, occasionally a clinical psychologist, and then some medicine sometimes on occasions. And metagenomics is changing that pathway.
I mean, is ruling out a pathogen for a lot of these people who have chronic diarrheal symptoms, and sometimes it can be amazingly debilitating. Leaving the house become a pretty big deal if you are anxious about that. What's the place of ruling out an infection or an infective bug, one that's totally not supposed to be there, a pathogen, in that instance?
What's interesting is because fecal PCR, do you know what? And I present as a gastroenterologist, but chronic disease that I see, fecal PCR seldom identifies the bug in that cause, to the point where often a GP will refer without even doing the test, probably scarred by the fact that they've done the test a million times before, and once or twice it comes, So the fecal PCR is great when it's positive, obviously appalling when it's not.
Sure.
And we'll repeat it.
Sure.
generally it's an unsatisfying test.
Yeah. I mean, and this is a good segue into why MetaPanel exists as a product. It's in large part, although not only, to help with those patients. And it's, so for the audience, you probably know this already, but the fecal PCR is the standard of care that is used widely in Australia. It is reimbursed by the Medicare benefit schedule. It tests about 10, maybe 12 pathogens, and it's the more common of those, maybe the most common 10. It misses the other 100 or thereabouts pathogens that do cause infections in the valve. And that's why MetaPanel exists, is that long tail, that less frequent but still important infections is why it exists. Could you just give your perspective on how MetaPanel's been, you've used MetaPanel
Sure.
in your practice?
So we did a study of 43 people. So and just for this audience, I get, like I had some concerns going into it about how we would use this test. So this is the MetaPanel pathogen test. And so 175 markers, key and evidence-based pathogens causing digestive disease beyond the small cluster that's tested in fecal PCR. And so we had 43 people. These were those that had come through our practice, have had endoscopy and colonoscopy, have come back to see me, have ongoing problems. And these aren't immaterial problems. So you mentioned sort of social isolation or anxiety about making certain they know where the lavatories are in David Jones when they're there. But these are folks who are also missing school, missing work, having been dismissed sometimes by other practitioners. And so these people come in, they were following a negative blood and endoscopy, the gold standard of gut health still, is debatable now, but traditionally the key arbiter of material GI disease, negative, would come to me, and I would usually have managed these entirely through discussion, presentation of the mechanism of irritable bowel syndrome, and then often referring on to a dietitian with some discussion about generic dietary advice. We found that 20% of those folks were positive for MetaPanel. So of those, in fact, 7 of them had actionable targets. They were treated and they resolved. And so, when I think about the barriers and my mindset going into the study as opposed to exiting the study, I was a bit concerned if you're testing for a whole lot of things. Am I going to get garbled information? Am I going to get more information than this? I didn't do neurology, I did gastroenterology, right? Is this brain of mine going to be able to manage the output that I get? That was resolved. So less than 2%, I think, in one of your bigger studies had more than one pathogen. So it wasn't that all of a sudden you're going to get 8 different pathogens and not know what to do with them. You get one pathogen, just like you do in a fecal PCR. It's just that you identify more pathogens and more patients. There was, one of your great an awesome partnership is with Sonic. And so you get a pathologist's perspective on how you treat it. And sometimes you get new microbes that you haven't previously treated because the PCR doesn't include them.
You could never look before.
And it gives you antibiotic advice. You go through it with your patient, you put them on it, and in our experience, they all got better. So that was, one was interpretability, the other was on how valuable is it going to be to the patient experience, and it was valuable. It was even occasionally valuable, to be honest, in folks who were negative. And so in those that were negative, the MetaPanel test does 2 things. in anxious folks who are certain that they've caught something from barley, or because they're immunosuppressed, or because they have some other chronic disease that they've got a bacteria, you can say, look, we've looked the best way we can possibly do it, and you don't. And that has therapeutic value. And the other part that it has is, diversity and richness. That leads on to other parts of the pathway, right? And then the other little part is, and this is around our more broader experience, is around payment. Australians, I had the mindset that Australians are a little bit addicted to absolutely free testing and healthcare. And we're a bulk billing practice. So our folks don't all live in the fancy part of town. They are people who are coming to see us because they can't be seen in a tertiary hospital. And by the time they get to us, they've missed work, they've had chronic symptoms over months to years. The $345 for Metapanel, they don't care about.
They've had enough.
They
want solutions.
So I think around those three things, they were my key concerns, and they were addressed.
So these were patients with, seriously bothersome illnesses, chronic diarrhea over long periods, who'd had the standard of care, who came to see you for a colonoscopy really as the last bit, and some of them may have even been repeat colonoscopies. And you've done Metapanel as the first new bit, and of those 20% you found a pathogen. You treated most of them, almost all of them.
Yeah, exactly.
And the ones you treated all got better.
Yeah, so exactly right. So, and the ones that were found, do you know what, they're an emerging group, and we're just a little bit uncertain whether what the right antibiotic is for them. And so, and they're actually, that they may be of that. I may have just missed an opportunity in two of the people. But in the 7 that I treated, they got better. They were delighted with doing the test. They were delighted with me because I was the person who was able to help them. And do you know what? Antibiotics are not the cure for everything, but when you've got an infection that's causing a disease, they're pretty good. Yeah.
Okay, well, that's great. Just moving on a little bit to talk about inflammatory bowel disease. And we're time's marching on a little bit. We need to be careful. No, not at all. Could you just give a little bit of, for the audience who they probably understand inflammatory bowel disease already, but just a high-level summary of what inflammatory bowel disease is. And then, we've got a couple of studies running in inflammatory bowel disease. Graham Raptor-Smith is a part of one of those, although independently in the SWIFT study. Could you give a bit of summary for the audience about what those findings roughly are and roughly what they mean for the management of IBD?
So inflammatory bowel disease is a fascinating condition. So your immune system is established in your body so that if it sees microbes, it can attack those microbes and can clear those microbes largely. So if you have strep pneumonia in your lung, your immune system goes bananas, you get something called pneumonia, you have antibiotics or otherwise, but in the old days you either died or your immune system cleared it. You had the crisis, I think they used to call it. Your fever would spike and then you'd clear it or not, and it goes away. So the body's immune system is driven to attack things that are not its own body. However, along your gastrointestinal tract, it's filthy by design. So you have 39 trillion microbes that are living cheek by jowl with your own cells. And so along the gastrointestinal tract, you need to have a mechanism of tolerance. So we have a range of ways of doing this. The appendix might help to educate the self into what's friendly and what's foe, what's valuable, what's a pathogen. But in inflammatory bowel disease, there seems to be a breakdown in immune tolerance for what we perceive to be within the spectrum of acceptable pathogen. And that's evolving, that idea. But certainly these people historically didn't have Shigella, didn't have Klebsiella, didn't have a key pathogenic trigger, at least identified by that fecal PCR. And so the immune system is overactivated. We know now about how important, it's not just one's immune system that's important, albeit it is important, but how important the microbiome is in this story. We know this from a range of reasons, most crudely, I guess, through fecal microbial transplantation, which can cure folks with mild to moderate disease. We know that diet is dramatically important with all of its important luminal factors. We know even appendectomy, most recently a month ago, can actually be as effective as some medicines in folks with ulcerative colitis, because it changes the microbiome. And, you know, through studies that I wasn't immediately involved with, but we know now that, you know, that the oral profiling can also identify people and can identify clinical flares and folks that aren't going to have clinical flares. Yeah.
And so the studies that we've run with MetaPanel on these patients, and Jake Begun, who's a well-known researcher at the MARTA and internationally renowned fellow, has run one of those studies. We're finding a lot of these patients with IBD flares have active pathogens.
Yeah, absolutely. So, you know, so Jake, I first met Jake when I was in New York at Columbia. Jake was doing the Mass General IBD fellowship, you know, the world's best IBD fellowship at, you know, at Harvard at Mass General. We were very lucky to get him out to Brisbane. You know, he's an amazing guy. You know, I think in his Crohn's disease study that he ran, 40% of their folks through the MetaPanel test, so the pathogen panel test, were identified. And I remember it being almost 3/4 or maybe slightly more than 3/4 of those pathogens wouldn't have been detected by fecal PCR. And my colleague at Integrated Gut Health, Graham Radford Smith, you know, another world leader in inflammatory bowel disease, he's from Oxford, the other great centre of IBD. Do you know what? In ulcerative colitis, there was also a key identification of non-fecal PCR identified pathogens in patients who were having flares. So they're the two main flavours of inflammatory bowel disease, slightly different but with many overlaps, Crohn's disease and ulcerative colitis.
And if you had a patient with a Crohn's flare and you detected a pathogen with MetaPanel, would you treat it? Yeah,
so you know what? So it absolutely would inform management. You know, so you would depending on the severity of the flare, but you would likely be putting them onto an antibiotic. You would be using that as part of your, you know, during that flare setting. Whereas in the past, all we had were very heavy, very severe immunosuppressants like cyclosporin that people use for transplants and other things. And when that doesn't work, surgery. And now we're bringing, you know, sort of microbial healthcare into that first line part of management.
Suppressing your immune system isn't very helpful if you've got infections.
Doesn't help, apparently.
Surprisingly. Okay. MetaPanel also does a whole bunch of testing for antimicrobial resistance genes.
Yes.
What's been your experience with those?
Yeah, so they're very important, and they're obviously something that doesn't get captured by standard testing. So there are a couple of things that MetaPanel, yes, it has more pathogens, but it also has both, you know, toxin-specific genes, you know, bacterial toxin-specific things that inform disease. And the antibiotic resistance aspects, you know, give you information about how to treat the person. So people who have been heavily exposed to different antibiotics in the past, you know, will frequently have an increased expression of this through means of transmission and horizontal gene transfer and other naughty things that bacteria do. And it informs our practice. Once again, do you know what? I was concerned how I would interpret all of this stuff that I've never encountered before. But once again, for the MetaPanel and for the MetaExplore test, in fairness, but there is strong, actionable advice, as there is for other testing that everyone's familiar with.
And I mean, you don't work in the public world anymore. Do you think there's a place for this in public hospitals?
So I see, you know, public medicine is the cornerstone of our acute and complicated disease management in the country. Digestive healthcare is a community sport, and that's why I've exited stage left for that. There are two massive use cases for MetaPanel and increasingly MetaExplore, but I'll start with MetaPanel. Because there is this digestive healthcare crisis, a lot of people, as a reflex, a knee-jerk reaction in primary healthcare where they can't manage it, will get referred to the Royal Brisbane or the PA or whichever, Royal North Shore, there you go, St V's, across Australia, who are inundated with a tsunami of digestive healthcare that they're totally ill-equipped to manage, nor should they be. They shouldn't be doing elective surgery. They shouldn't be giving people pap smears or vaccinating. They can't manage long. But nevertheless, that's where they'll be headed. So they want to moderate that tsunami. Pretty hard to moderate a tsunami. Unless you have a test where folks with diarrhea, 20% of them will have an actionable target. That can be rinsed, and hopefully not repeated, but can be recycled. And what hospitals are increasingly good at with workflow programs is you need these 5 tests before you get an outpatient appointment. My wife's an endocrinologist. You need your TFTs, you need your thyroid peroxidase antibodies, and I'll stop right there before I get into the week. So you need this list of things before you get onto the waiting list. All of a sudden, only 80% are getting through because 20% are going back to the GP. So the use case in public hospitals that can't manage these folks effectively, there will be MetaPanel will have a great opportunity for triage. State government's going to love you for that. The waiting lists are down. You're not clogging up elective waiting lists for other things and gastroenterology and other outpatient lists. And patients will get better quicker. So your patients will love you. So, and your GPs will love you because you're sort of liberating it. Maybe the state government even pays for it, I would think. So there's that use case. And then there's the use case in community. You know what? As we're saying, we do 10,000, 12,000 a year. We want to do 100,000 a year. So all of a sudden you do that by delivering great care. And so we want to be the group that's delivering this because 20% of our patients are getting better, whereas the other mob down the road, all of them are not getting better. So, we see it as a discriminating part of our management care. We see it as an opportunity to engage with our community and our patients. Other folks who can't do that will see it as an opportunity of making certain that only the most severe, most unmanageable patients get through the SIV.
We'll come back to that. Really keen to get that business perspective on that in a minute. Graham Radford-Smith, who's the, I guess now principal of the colonoscopy clinic, who you acquired his business, the Integrated Gut Health Clinic. He's one of the users of MetaExplore. Could we just shift gears now and just talk about MetaExplore as a product and the experience that you've had in the clinic of MetaExplore, Graham in particular has had with that, and what do you think the future is of MetaExplore as a product?
So where do we see it in the algorithm? Folks coming in with chronic diarrhea, we often are now applying MetaPanel. First up for these folks.
So it's rule out a pathogen.
Rule out a pathogen. 80% still having chronic symptoms coming through to us.
20% find pathogen, treat pathogen.
Have been managed. Patient happy. Back to the GP. And you know what? There'll be a significant 70% of that group, 75% of that group who actually, because MetaPanel, interestingly, we overlooked it, isn't just the pathogen panel, but in fact, I don't know who came up with that idea. It's a good idea. It's pathogen plus, so it also has these 2 other markers of dysbiosis, which is an important topic of richness and diversity. How many different species are represented in this person? Dysbiosis is an imbalance of the composition, function, metabolic activity of your microbiome associated with symptoms or disease states. So many of these people will be dysbiotic.
Yep.
And, we see, all of that 80, but particularly the 75% of the 80% who are dysbiotic coming through for further characterisation.
Okay. So these people that still have problems, they don't have a pathogen, they've had a colonoscopy, you can't find an organic or an anatomical cause for it, and they're still not happy. These are not resolved.
They're folks that can't be fixed with 5 days of ciprofloxacin. Yeah. So this is a huge group. This is that massive tip of the iceberg. And these folks have often had chronic symptoms, often dismissed.
Yeah.
And it has been difficult to manage these folks. So what Graham has done is he has assembled an awesome team and has gone all in on MetaXplore to understand how to use it. Graham has now probably the biggest experience in Australia, probably, I think, of MetaXplore in the clinical setting. And so what he's done is he's evolved an acute induction pathway whereby he gets these people, he sees them, he organises MetaXplore GI for them. They get a profile, and he has the same. And he shared with me he had the same concerns over the barriers and the same appreciation now for why they're not barriers. And then implements basically a dietary and lifestyle prescription. And these folks who can be difficult to manage, when you incorporate understanding their gut microbiome and the gut biomarkers that MetaXplore includes. So it is both the composition, the function, and the metabolic activity.
Right.
It goes across what dysbiosis is. You're able to have actionable diet, actionable lifestyle, sometimes identifying people that will most benefit from clinical psychology. And why his practice is called integrated gut health is that one of the things that's allowed him to integrate gut health is this new technology and new testing. So he's had a great experience with it, and that's why we wanted to be part of that story.
Yeah, I mean, a lot of these patients end up with the integrated health world, so in the naturopath, dietitian world at the minute, and whilst they're almost always engaged with mainstream medicine, mainstream medicine hasn't really been able to deliver them solutions, and hence the need to look elsewhere. Graham is really blazing a new trail there in the healthcare space of figuring that out. Do you think this is going to spread beyond those innovators like Graham into the broader medical community?
Yeah, so yes. So the reason from as a holistic doctor perspective, sure.
Yeah.
From a corporate perspective, absolutely. So Graham and all of us have been colleagues for a long period of time, but Graham presented his data at the Microbial Healthcare Symposium I ran with 200 folks from across the world who were all presenting their data. He presented his induction data using MetaXplore, as did Abby Marsh, who's his key dietitian. Andrew was there, I was there, David was there, and we just knew that was the future of our practice.
Right.
Colonoscopy, from a corporate point of view, has enormous value for practitioners who take the lion's share of the revenue. The key part of a practice mindset is developing structures around how you can deliver real value for the patient clinically, and he has, as well as revenue coming through to the practice. And Andrew's better to speak to that than I am. But where it isn't filtered through a clinician. So the flywheel of medicine is always non-clinician activity, And we knew that in our space, fecal metagenomic testing and the lifestyle aspects of that were where we had to be.
Okay.
Yeah.
Well, thank you, Dan. That's terrific. Andrew, the business brains behind the clinical brawn here. Can you just talk about how you see these products, MetaPanel and MetaExplore, which are unique in their fields, really impacting your practice at colonoscopy clinic?
Yeah, I mean, I think, experience to date, the results are compelling, they're definitive, they're actionable, and we see it, live it, realize it. The markets, I guess the end markets and the patient communities we're serving are number one, increasing in size. We've all seen the stats on colon and bowel cancer. We all know the stats on gut health. It is a pandemic in its own right, as Dan and Sean have talked to.
And I should just say, early onset colorectal cancer just last week was shown to be due to a paediatric infection in large part, which is interesting. So,
and so I think these are big markets, compelling tests which are easy to use, easy to order, quick to get results in, actionable for the clinicians. And how's it going to change our practice? People at the moment come to us for bowel cancer prevention because they want to get an endoscopy, colonoscopy, or they come to us to get tip-top sort of comprehensive integrated gut health care. Going forward, people will find us because they want to figure out what's going on with their microbiome. We will start getting referrals, and we already are getting referrals because of MetaExplore, because of microbiome. And I think that's where it's going to go. Big end markets, highly personalized, great test that's easy to interpret, easy to action, and will be a key part of, I think, every, not only gastroenterology practice, but I dare say in the future, GP practices, naturopaths, so on like that. That's the only way we're going to, solve this pandemic.
And it's a way of maintaining engagement with our population group, right, Andrew?
Yep.
Whereas we maybe touch base with them once every 5 years.
Yeah, that's changing.
To change that into a cyclical thing, and a cyclical engagement requires cyclical and changing information. And the one thing that changes quarterly is your microbiome.
Yeah. Okay. Understood. Look, gentlemen, I greatly appreciate your time here. We are going to open this up to questions from the audience. So if there are any questions from the audience, please feel free to type those into the chat, or feel free to raise a hand and we can ask you directly.
Elise Shapiro.
Yeah. Elise.
Great, thanks. Hi guys, thanks so much for the session. Incredibly useful insights. Look, Dr. Worthley, you're probably one of the earlier adopters of this sort of technology, and really have a good understanding of how microbiome kind of has a role in a lot of these underlying disorders. When you talk to other physicians, especially in the GI space, but also maybe kind of integrative GPs, how much awareness is there? How much kind of a willingness to accept GI testing as a protocol do you think there is? Thanks.
Yeah, so great question, Elise. Do you know what? When I did my postdoc 10 years ago, there wasn't. I should have chosen maybe I should have done it in Brisbane, rather than go to New York. But there certainly wasn't the clinical exposure to microbial health care. Do you know what? There is universal acknowledgement across all doctors that gut health is important. I genuinely, there will be people where they haven't understood how it applies to their practice. Absolutely. And gastroenterology is, of course, one where it more directly and more obviously and as in a narrative sense makes, perfect, is a perfect opportunity to apply. But no one, I feel, even though we've more rapidly integrated it into our practice and we have a greater experience of it, and thus perhaps those barriers that I had even before I did the study, not that I doubted that the microbiome and microbiota was important, but I doubted how I would apply it. and how easy it would be to apply, how I would action it. So I don't think, everything from in all the lay press, from the New York Times to Time Magazine to the Australian to the Courier Mail, right? You've got people that are fascinated by fecal microbial transplantation, what their gut health is in inverted commas, and how it relates to them. I think the part for adopting will be in traditional healthcare will be exposure to these case studies and experiences about how easy it is to apply. And integrate into their standard workflow, and how it won't cost them money to integrate. Their patients will get better, and it won't make them feel stupid. Those three things. And I've seen some of the next gen types of patient interpretations and applicability that are coming online through Microba, and they won't feel stupid. Their patients will get better, and they'll adopt it. So no one doubts it's important. People are concerned how they'll implement it as being probably your key barrier. That barrier for me in my practice, which is standard, traditional, it's not integrative. We've got integrated gut health, but I'm your bog standard private gastroenterologist. It was easy. So as those sorts of experiences get told initially by folks in Brisbane by us, in Sydney by Dr. X, Y, and Z, in Melbourne, Adelaide, etc., those presentations will snowball, I think. And so, fecal PCR, I think, will go away. People will just do metapanel, I think. Certainly in the public space, it'll be used publicly, funded by state governments to help triage their waiting lists, and it will be used by caring folks who both want to help their patients and have a practice mindset in the community. I don't see another option coming along that's going to change that. Sorry, at least it's a bit long.
No, that's really helpful. Maybe just one more as a bit of a follow-up, if that's okay. I mean, when you talked about just now kind of replacing fecal PCR, you said fecal PCR will go away and people will just do metapanel. I mean, are there any other microbiome tests that you employ, or do you see metapanel as kind of gold standard, and why?
Yeah, so there are other stool tests. Absolutely, Phil and Jean were some of the world's best scientists in the space who founded Microba. Where the moat is perhaps at its broadest is around the application, and it is the partnership with Sonic has perhaps also helped that in terms of I can order it on my pad. It's the only stool test apart from fecal PCR that I can order on my pad. Once you're on the pad, you get ordered a lot more. And that's the way we do it. So it's just I do my standard barrage of tests, not the sodium and potassium that my dad used to do, but the barrage of the biochemistry that is now a simple ELFT tick, and metapanel gets the tick for the PCR for the pathogen part. Do you know what? People are busy. People are tired of their symptoms. I just think, there's no harm in doing both of them. Fecal PCR is free currently. Well, it's not free, is it? But the government pays for it. But you're not going to do the test where someone comes to see you, you do one thing that you think is unlikely going to be positive, and they take another day off work to come and get those results, and then you order the test that you think you should have ordered in the first place. People are just as resistant time wastage as money wastage, I think. So that at least in our practice, that's why. And I think other folks may do other approaches depending on how busy they are. But in busy practices, they'll likely for pathogen testing go directly to MetaPanel. I think probably MetaPanel and MetaExplore may continue to be sequential, maybe in the majority of practices, at least until we have more evidence as to how they're best deployed.
Thank you, Dan. We will go to, there's a couple of questions in the chat. Thank you. We'll get to those in a moment. We might go to, first of all, to Thomas Joachim.
Thanks. Yeah, thanks, guys. And I think maybe you've kind of answered the question I had just at the end there. It's really talking about the sequential use of whether it's either, you know, current PCR tests followed by MetaPanel, followed by MetaExplore. That seems to be a bit of a trend as to how you best, you know, at least for MetaPanel first, followed by MetaExplore second, seems to be how you best envision using these products. Is that fair to say that you think that will continue to be the case rather than, you know, combining them up front? And I guess, yeah, any further comment on that would be helpful.
Yeah, so that's such a great question. And so we're currently doing a study whereby patients who are coming in for endoscopy and colonoscopy for chronic gastrointestinal symptoms prior to their endoscopy and colonoscopy are having both. So are having MetaPanel and MetaExplore. And so at the end of the procedure, they will have had, Tom, like their colonoscopy. So they will have had their endoscopy, their colonoscopy. They're not going to die of bowel cancer. But more than that, actually, I'm able to articulate a comprehensive plan for them. That's nourishing from, well, potentially nourishing. We're yet to do the study. But, you know, it's nourishing from a practitioner perspective in terms of being able to give more detailed advice rather than there was no endoscopic explanation for your symptoms, which, you know, I don't give that. I give a more holistic view on possibilities, but to be able to provide a luminal, a microbial perspective to looking and thinking at the same time, you know, may have real value for these patients. It may be that sometimes it gets done together, and it may be that sometimes it's done sequentially and sonic for those people who are dysbiotic and richness, you know, prompt like radiology groups do. You know, your ultrasound found a mass, maybe an MRI would be valuable. Please call us if you'd like. You know, there may be that iterative link and offering the next step. You know, I'm not involved with how that might get packaged, but as a practitioner, I see, you know, MetaPanel followed by MetaExplore being a logical and easily sort of an easy narrative to give to your patients in terms of what we're doing now and why, and if that doesn't work, what we'll do next.
Well, I think just to add to that, maybe Sean, if there's a pathogen, you want to know about it, you want to detect it, you want to get rid of it and address it up front, that's MetaPanel. So absolutely done up front, probably before any of the other interventions we would usually do, you know, procedurally or in terms of management. MetaExplore, I think, is that for us, that is the retesting. At the moment, there's not a definitive, you know, really definitive test that's widely adopted. That's the role MetaExplore will play in clinical practice. I've now got a score, I've got some actionable things I can do, I've got a test result, and then come back in 3 months, 6 months' time. And we honestly don't know at the moment, but I mean, our view is this could likely become a quarterly test that we do or maybe administer as part of an annual subscription for health services and health management services ongoing. End outcomes, you know, massive impact on reducing bowel cancer risk factors and also significantly addressing symptoms and symptom management and resolution for a whole range of gut health disorders and conditions.
Yeah, thanks very much, Andrew. I took the words right out of my mouth about you got to treat a pathogen. If you see a pathogen, step one, treat pathogen, and then what comes afterwards is very important. Let's go to Ian Wilkie.
Hey, thanks, guys. Look, you pretty much just answered my question. It was really around that clinical algorithm and when you'd sort of see the tests being implemented and when, and then it was the question around the test and retest and what you sort of saw on that. So don't worry about me. You've already answered that. So thank you very much.
Thank you, Ian. We have a couple of questions online. The first is really a question for Microba as opposed to Dan regarding any conversations with Medicare or private health insurers on health economics of reimbursement. I can say that this is not really a question for Dan, so I can take that and say that Microba is acutely aware that being able to take this product through a reimbursement pathway makes a lot of sense. The first part of that is collecting the data to be able to support those approaches. And Microba is well and truly focused on collecting that data to support that. That includes folding in expertise around health economics to ensure that we can justify value. It's not just clinical benefit, it's about the overall economic benefits to healthcare systems. So that is very much one of the work streams happening here at Microba. And then the next question, which we have from Derek Jelinek, is what limitations or concerns do you have about Microba's platform?
Yeah, it's a great question. So, I outlined some of my earlier concerns. The longer term is how the serial testing and the pathway that involves. And so what we need to prove, and we've proven it with the diagnostic test, the metapanel pathogen test, that people get better. And the reason we've proven that is because that's a short-term fix: antibiotics, symptoms, antibiotics, resolution, and that's an easy thing to confirm and to prove. Longer term, however, diet and lifestyle is a tough nut to crack. What we envisage is that through MetaXplore testing, we will be able to establish a baseline and we'll be able to establish biofeedback, a management that people see real value in. We are investing as a practice in that through personnel and time in order to develop that pathway. We think that will be important, will lead to patient symptom resolution, and patients will see value in. And I think if that is true, and serial MetaXplore testing is an integral part of that, and that's what we think will happen, that's wonderful. But I guess my concern could be is what additional benefit does serial testing have? Genetic studies with 23andMe can be done once, right? And that's a huge limitation to them. What's valuable with MetaXplore is that you are ever changing. As that great book by Ed Yong was, what is it? I Contain Multitudes, from that Walt Whitman poem. And so what that means is you are a swarm and you are ever changing, and your doctor has a part in steering you towards health. But we don't know that's true. We just have invested in that future.
I think what I might add is like what we knew about Microba from a couple of years ago is the science, the evidence, the tech, the quality is really impressive. What has been outstanding in the past 6 months or so, as we've really increased our partnership, is the go-to-market approach, product feedback, getting out there on the ground, listening to customers, partnering with people, studies in place, solving issues to make it simple, easier to order the test, shortening the cycle time to get the test results back, making sure that the results are easy to understand, interpret, and action. And that's the gold. That's been fantastic.
Andrew, thank you very much. That's a great way to wrap things up here. We are at the top of the hour. We've ticked over. We have got through all the questions. I don't think there's any more hands up. And so unless there is any last moment quick things that pop up in the chat, which it looks as though there's not, I'll thank you both for your time.
Thank you very much, Sean. Cheers. Thank you.
Thanks, everyone.
Thank you. Lovely to speak with you.
To the audience for joining us.